Movements of GI tract, gastric motility and intestinal motility. Two types of movements occur in the gastrointestinal tract. Propulsive movements, which cause food to move forward along the tract at an appropriate rate to accommodate digestion and absorption. Then mixing movements will be taking place, which keep the intestinal contents thoroughly mixed at all times. Then propulsive movements or peristalsis. The basic propulsive movement of the gastrointestinal tract is peristalsis, which is illustrated. A contractile ring appears around the gut and then moves forward. Any material in front of the contractile ring is moved forward. Peristalsis is an inherent property of many syncytia smooth muscle tubes stimulated at any point in the gut can cause a contractile ring to appear in the circular muscle, and this ring then spreads throughout the gut tube. Peristalsis also occurs in bile ducts, glandular ducts, ureters, and many other smooth muscle tubes of the body. The usual stimulus for intestinal peristalsis is distension of the gut. That is, if large amount of food collects at any point in the gut, the stretching of gut wall stimulates the enteric nerve system to contract the gut wall 2 to 3 centimeters behind this point, and a contractile ring appears that initiates a peristaltic movement. Other stimuli that can initiate peristalsis include chemical or physical irritation of the epithelial lining in the gut. Also, strong parasympathetic nerve system to the gut will elicit strong peristalsis. Then, function of the myenteric plexus in peristalsis. Peristalsis occurs only weakly or not at all in any portion of the gastrointestinal tract that has congenital absence of the myenteric plexus. Also, it is greatly depressed or completely blocked in the entire gut when a person is treated with atropine to paralyze the cholinergic nerve endings of the myenteric plexus. Therefore, effectual peristalsis requires an active myenteric plexus. And directional movement of peristaltic waves toward the anus. Peristalsis theoretically can occur in different direction from a stimulated point, but it normally dies out rapidly in the orad direction while continuing for a considerable distance toward the anus. The exact cause of this directional transmission of peristalsis has never been identified, although it probably results mainly from the fact that the myenteric plexus itself is polarized in the anal direction, which can be explained as follows. Peristaltic reflex and the law of the gut. When a segment of the intestinal tract is excited by distension and thereby initiates peristalsis, the contractile ring causes the peristalsis normally begins on the orad region, orad side of the distended segment and moves toward the distended segment, pushing the intestinal contents in the anal direction for 5 to 10 centimeters before dying out. At the same time, the gut sometimes relaxes several centimeters downstream toward the anus, which is called a receptive relaxation, thus allowing the food to be propelled more easily anally than orad. This complex pattern does not occur in absence of myenteric plexus. Therefore, the complex is called the myenteric reflex or the peristaltic reflex. The peristaltic reflex plus the anal digestion of direction of movement of the peristalsis is called the law of the gut. So, peristaltic contraction, leading wave of distension, 0 time, 5 seconds later, peristalsis will be taking place. Then mixing movements are also occurring. Mixing movements differ in different parts of the alimentary tract. In some cases, the peristaltic contractions themselves cause most of the mixing. This is especially true when forward propagation of the intestinal content is blocked by a sphincter, so that a peristaltic wave can then only churn the intestinal contents rather than propelling them forward. At other times, local intermittent constrictions contractions occur every few centimeters in the gut wall. These constrictions usually last only 5 to 30 seconds, then new constriction occur at any point in the gut. This chopping and shearing of the contents first here and then there. These peristaltic and constrictive movements are modified in different parts of the gastrointestinal tract for proper propulsion and mixing. Then deglutition, swallowing or deglutition is a complex reflex mechanism by which food is pushed to the oral cavity into the esophagus and then pushed into the stomach. This movement of food from the oral cavity onto the esophagus and stomach by pushing is called propulsion, and it is important part of digestive process. Food is first ingested into the mouth and then broken down into mouth by chewing or mastication, tongue movements, saliva, and teeth grinding it until it becomes a bolus, a soft mass. The food bolus is soft enough that it can easily be swallowed and propelled through the alimentary canal. Once food is swallowed from the mouth, it moves into the oropharynx, laryngopharynx, and then passes into the esophagus and into the stomach. Food is propelled in this direction by peristalsis or peristaltic contractions. These are altering involuntary contractions and relaxations of smooth muscle compound surrounding the digestive tract. Contraction happens before the bolus to propel it on, while muscles after bolus relaxes to allow the bolus room to pass. This complex process of swallowing involves the coordination of 22 different muscle groups involving the oral cavity, pharynx, and esophagus. Swallowing is divided into three stages: oral phase or voluntary state, voluntary movement of the bolus from the oral cavity into the oropharynx, and pharyngeal phase or involuntary phase, involuntary movement of the bolus from the oropharynx to the esophagus, esophageal phase, involuntary movement of the bolus to the esophagus and into the stomach. And voluntary stage of swallowing in detail. The oral phase of swallowing is the first stage of deglutition and it is a voluntary process. It is also commonly known as the buccal phase. It involves a contraction of the tongue to push the bolus up against the soft palate and then posteriorly into the oropharynx by both the tongue and the soft palate. When the food is ready for swallowing, it is voluntarily squeezed or rolled posteriorly into the pharynx by pressure of the tongue upward and backward against the palate. The involuntary phase stage of swallowing. As the bolus of food enters the posterior mouth and pharynx, it stimulates epithelial swallowing receptor areas all around the opening of the pharynx, especially on the tonsillar pillars, and impulses from this pass to the brainstem to initiate a series of automatic pharyngeal muscle contractions as follows. The soft palate is pulled upward to close the posterior nares to prevent a reflux of food into the nasal cavities. The palatopharyngeal folds on each side of the pharynx are pulled medially to approximate each other. In this way, these folds form a sagittal slit through which the food must pass into the posterior pharynx. This slit performs a selective action, allowing food that has been masticated sufficiently to pass with ease. Because this stage of swallowing lasts less than 1 second, any large object is usually impeded too much to pass into the esophagus. The vocal cords of the larynx are strongly approximated and the larynx is pulled upward and anteriorly by the neck muscles. These actions combined with the presence of ligaments that prevent upward movement of the epiglottis causes the epiglottis to swing backward over the opening of the larynx. All these effects acting together prevent passage of food into the nose and trachea. Most essential is the tight approximation of the vocal cords, but the epiglottis helps to prevent food from ever getting as far as the vocal cords. Destruction of the vocal cords or from the muscles that approximate them can cause strangulation. The upward movement of larynx also pulls up and enlarges the opening to the esophagus. At the same time, the upper 3 to 4 centimeters of esophageal muscular wall, called the upper esophageal sphincter, also called the pharyngopharyngeal sphincter, relaxes, thus allowing food to move easily and freely from the posterior pharynx into the upper esophagus. Between swallows, the sphincter remains strongly contracted, thereby preventing air from going into the esophagus during respiration. The upward movement of the larynx also lifts the glottis out of the mainstream of food flow so that the food mainly passes on each side of the epiglottis rather than over its surface. This adds still another protection against entry of food into the trachea. Once the larynx is raised and the pharyngeal sphincter becomes relaxed, the entire muscular wall of the pharynx contracts, beginning in the superior part of pharynx, then spreading downward after the middle of inferior pharyngeal areas, which propels the food by peristalsis into the esophagus. To summarize the mechanics of pharyngeal stage of swallowing, the trachea is closed, the esophagus is opened. The last peristaltic wave, initiated by the nervous system of the pharynx, forces the bolus of food into the upper esophagus. The entire process occurs in less than 2 seconds. Next, esophageal stage of swallowing. The final stage of deglutition is the esophageal phase. The esophagus normally exhibits two types of peristaltic movements: primary peristalsis and secondary peristalsis. Primary peristalsis is simply continuation of the peristaltic wave that begins in the pharynx and spreads into the esophagus during the pharyngeal stage of swallowing. This wave passes all the way from the pharynx to the stomach in about 8 to 10 seconds. If the primary peristaltic wave fails to move into a stomach, all the food that has entered the esophagus, secondary peristaltic waves result from distension of the esophagus itself by the retained food. These waves continue until all the food has emptied into the stomach. The secondary peristaltic waves are initiated partly by intrinsic neuron circuits in the myotonic nerve system and partly by reflexes that begin in the pharynx and then transmitted upward through vagal afferent fibers to the medulla and back again to the esophagus through glossopharyngeal and vagal afferent nerve fibers. The musculature of the pharyngeal wall and upper third of the esophagus is striated muscle. Therefore, the peristaltic wave in these regions are controlled by skeletal nerve impulses from the glossopharyngeal and vagus nerve. In the lower two-thirds of esophagus, the musculature is smooth muscle, but this portion of the esophagus is also strongly controlled by the vagus nerve acting through connections with the esophageal myotonic nerve system. And the vagus nerve to the esophagus are cut. The myotonic nerve plexus of the esophagus becomes excitable enough after several days to cause strong secondary peristaltic waves even without support from the vagal reflex. Therefore, even after peristalsis of the brainstem, swallowing reflex, food fed by tube or some other way to esophagus still passes readily into the stomach. Like the pharyngeal phase, this process is involuntary. Which process? Esophageal phase. The food bolus is forced inferiorly from the pharynx into the esophagus after the sequential contraction of the three pharyngeal constrictor muscles, the superior, middle, and inferior constrictor muscles, which together make up the external circular layer of pharynx. This muscle contraction creates a peristaltic ridge. One of the food bolus has fully entered the esophagus. The upper esophageal sphincter will contract and close again. The food bolus then moves through the esophagus via peristalsis. The sequential contraction is adjacent smooth muscle to propel food in one direction. Gravity also aids in the movement of food to the stomach. The esophagus pierces the diaphragm at the esophageal hiatus and continues to join the stomach at the cardiac orifice, which is surrounded by the lower esophageal sphincter. It is also known as gastroesophageal sphincter or cardiac sphincter. As the bolus approaches the stomach, the lower esophageal sphincter around the cardiac orifice will open and allow the food bolus to pass into the stomach. Once the bolus has entered, the lower esophageal sphincter will close to prevent regurgitation of stomach contents, therefore protecting the esophagus from acid reflux. And is about stomach emptying. Gastric emptying is the process by which contents of the stomach are moved into the duodenum. Stomach emptying is promoted by intense peristaltic contractions in the stomach antrum. It is accomplished by three mechanisms: peristaltic waves, systolic contractions of the antrum, and reduction in size of stomach. Liquids will ordinarily empty faster than solids and smaller objects faster than larger. The gastric emptying rate is carefully regulated process consisting of different phases: metabolic load, neutral regulatory mechanisms, and hormonal influence achieve a balanced emptying of contents from the stomach into the duodenum for absorption in the small intestine. The rate of gastric emptying is strongly influenced by both volume and composition of gastric contents, which makes considerable sense. Then, intense antral peristaltic contractions during stomach emptying is the pyloric pump. Most of the time, rhythmical stomach contractions are weak and function mainly to cause mixing of food and gastric secretions. However, for about 20% of the time, while food is in the stomach, the contractions become intense, beginning in mid stomach and spreading through the caudal stomach, no longer as weak mixing contractions but as strong peristaltic, very tightly ring like constrictions that can cause stomach emptying. As the stomach becomes progressively more and more empty, these constrictions begin faster and further away up the body of the stomach, gradually pinching off the food in the body of stomach and adding this food to the chyme in the antrum. This intense peristaltic contractions often create 50 to 70 centimeters of water pressure, which is about 6 times as powerful as the useful mixing type of peristaltic waves. When pyloric tone is normal, each strong peristaltic wave forces up to several milliliters of chyme into the duodenum. Thus, the peristaltic waves, in addition to causing mixing in the stomach, also provide a pumping action called the pyloric pump. So, role of pylorus in the controlling stomach emptying. The distal opening of the stomach is the pylorus. Here, the thickness of the circular wall muscle becomes 50 to 100% greater than the earlier portions of the stomach antrum, and it remains slightly tonically contracted almost all the time. Therefore, the pyloric circular muscle is called the pyloric sphincter. Despite normal tonic contractions of the pyloric sphincter, the pylorus usually is open enough for water and other fluids to empty from the stomach into the duodenum with ease. Conversely, the constriction normally usually prevents passage of food particles until they have become mixed in the chyme to almost fluid consistency. So, regulation of stomach emptying. The rate at which the stomach empties is regulated by signals from both the stomach and the duodenum. However, the duodenum provides by far the more potent of the signals, controlling the emptying of chyme into the duodenum at a rate no greater than the rate at which the chyme can be digested and absorbed in the small intestine. And gastric factors that promote emptying. Effect of gastric food volume or rate of emptying. Increased food volume in the stomach promotes increased emptying from the stomach, but this increased emptying does not occur for reasons that we would expect. It is not increased storage pressure of the food in the stomach that causes the increased emptying, because in the usual normal range of volume, the increase in volume does not increase the pressure much. However, stretching of the stomach wall does elicit local myenteric reflexes in the wall that greatly attenuate the activity of the pyloric pump and at the same time inhibit the pylorus. Gastric factors that promote emptying. Effect of gastric food volume, which we just learned. Then effect of the hormone gastrin on stomach emptying. The stomach wall stretch and the presence of certain types of foods in the stomach, particularly digestive products of meat, elicit release of hormone called gastrin from the antral mucosa. This has potent effects to cause secretion of highly acidic gastric juice by the stomach glands. Gastrin also has mild to moderate stimulatory effects on motor functions in the body of the stomach. Most important, it seems to enhance the activity of the pyloric pump. Thus, it too probably promotes stomach emptying. Emptying of the stomach is controlled only by a moderate degree by stomach factors such as the degree of filling in the stomach and the excitatory effect of gastrin in stomach peristalsis. Probably the more important control of stomach emptying resides in inhibitory feedback signals from the duodenum, including both enterogastric inhibitory nerve feedback reflex and hormonal feedback by CCK, cholecystokinin. This is a hormone. These feedback inhibitory mechanisms work together to slow the rate of emptying when too much chyme is already in the small intestine, or the chyme is excessively acidic, contains too much unprocessed protein or fat, is hypertonic, or is irritating. In this way, the rate of stomach emptying is limited to that amount of chyme that the small intestine can process. Then defecation, movement of feces, undigested food, bacteria, mucus, and cells from the lining of the intestine through the bowel and out of the anus, also called bowel movement. Defecation is the term given for the act of expelling feces from the digestive tract via the anus. It is a complex function that requires coordinated involvement from the gastrointestinal system, the nerve system, as well as the musculoskeletal system. The frequency of defecation within a 24-hour period varies depending on age and diet, but most people tend to have a bowel movement 1 to 3 times daily. Most of the time, the rectum is empty of feces. It results partly from the fact that weak functional sphincter exists. A weak functional sphincter exists between 20 centimeters from the anus at the jaundice between the sigmoid colon and the rectum. This is also a sharp angulation here that contributes additional resistance to filling the rectum. When a mass movement of vehicle forces feces into the rectum, the desire for defecation occurs immediately, including a reflex contraction of the rectum and relaxation of the anal sphincter. Continual dribble or fecal matter through the anus is prevented by tonic constriction of one internal anus sphincter and several centimeters long thickening of the circular smooth muscle that lies immediately inside the anus, and an external anal sphincter composed of striated voluntary muscle that both surrounds the internal sphincter and extends distal to it. The external sphincter is controlled by the nerve fibers in the pudendal nerve, which is a part of somatic nerve system and therefore is under voluntary, conscious or at least subconscious control. Subconsciously, the external sphincter is usually kept continuously constricted unless conscious signals inhibit the constriction. In defecation reflex, ordinarily, defecation is initiated by defecation reflex. One of these reflexes is the intrinsic reflex, mediated by the local enteric nerve system. First is intrinsic reflex, mediated by the local enteric nerve system in the rectal wall. This can be described as follows. When feces enter the rectum, distension of the rectal wall initiates afferent signals that spread through the mynderic plexus to initiate peristaltic waves in the descending colon, sigmoid and rectum, forcing feces toward the anus. As the peristaltic wave approaches the anus, the internal anal sphincter is relaxed by inhibitory signals from the mynderic plexus. If the external anal sphincter is also consciously, voluntarily relaxed at the same time, defecation occurs. The intrinsic mynderic defecation reflex functions by itself normally is relatively weak to be effective in causing defecation. It usually must be fortified by another type of defecation reflex, a parasympathetic defecation reflex that involves the sacral segments of the spinal cord and the nerve endings in the rectum are stimulated. Signals are transmitted first into the spinal cord and then reflexly back to the descending colon, sigmoid, rectum, and anus by way of parasympathetic nerve fibers and the pelvic nerves. These parasympathetic signals greatly intensify the peristaltic waves as well as relax the intestinal anal sphincter, thus converting the intrinsic mynderic defecation reflex from a weak effort into a powerful process of defecation that is sometimes effective in emptying the large bowel all the way from the splenic flexure of the colon to the anus. So defecation signals entering the spinal cord initiate another effect such as taking a deep breath, closure of the gluteus and contraction of the abdominal wall muscles to force the fecal contents to the colon downward, and at the same time cause the pelvic floor to relax downward and pull outward on the anal ring to evaginate the feces. When it becomes convenient for the person to defecate, the defecation reflex can purposefully be activated by taking a deep breath to move the diaphragm upward and then contracting the abdominal muscle to increase the pressure in the abdomen, thus forcing fecal contents into the rectum to cause new reflexes. So reflexes initiated in this way are almost never be effective as those that arise naturally, for which reason people who too often inhibit their natural reflexes are likely to become severely constipated. In newborn babies and in some people with transected spinal cords, the defecation reflex causes automatic emptying of the lower bowel at inconvenient times during the day. Because of lack of conscious control exercised through voluntary contraction or relaxation of the external anal sphincter. That is shown here from conscious cortex, afferent nerve fibers, parasympathetic nerve fibers, pelvic nerves, ascending colon, skeletal motor nerve, rectum, sigmoid colon, and external anal sphincter, and internal anal sphincter is also there. Afferent and efferent pathways of the parasympathetic mechanism for entering the defecation reflex.